thank you all for coming. Glad to see you guys here. If you all want to, you're welcome to scoot forward a little bit so we're not so far back. We only got a small panel and they're all sitting. I don't want them to be hiding behind the podium. So if you guys want, feel free to move up.
Please.
Also, they want you to move up, so please move up. Cool. So this is the Repairing the Breach, piloting a community health team out of a faith-based free healthcare center. We got a team up here. Dr. Martha Carlo is here. We got Jonathan, Aaron, and Namrita. Thank you. And I'm supposed to let you guys know that you can get credit for this for CME, CD, and nursing. They haven't told me how you get that, but you can. So ask somebody who knows. And without further ado, here's the squad.
Hey, I'll just open us with a prayer, with a collect for Thursday from the Book of Common Prayer, if you know it. But either way, we can bow our heads and pray. Heavenly Father God, in you we live and move and have our being. We pray you so to guide and govern us as may be best for us, granting us in this world knowledge of your truth, and in the age to come, life everlasting. Amen.
Okay, thanks for being here. We are going to switch around speakers, but everybody will come up here and just hold this. I would like to introduce our team and the topic. We have entitled this Repairing the Breach, piloting a community health team out of a faith-based clinic. These are all students that I have worked with, which has been a dream. And this might look like a polished presentation, but we're here to sort of present an idea. Lots of stuff that we've been working on and thinking about, some things that have worked well, some things that haven't. So this is very much an opportunity for us to enter in this together. We'll each introduce ourselves briefly. So I'm Martha Carlo. I'm a family physician. The first time I attended CCHF was in 1988 as a medical student in Philadelphia. It was in like a church basement and we had potlucks for dinner. So we've come a long way, baby. I practiced in Nepal as a missionary for about 10 years. I was about 20 years on faculty at UNC, Chapel Hill and Family Medicine. And now I predominantly work for the Theology and Medicine program when we are downstairs with a booth at Duke Divinity, if you want to hear more about that. And I work part-time as a physician at Samaritan Health Center.
Hey, y'all. My name is Jonathan Avendaño. I'm a brand new third-year medical student at the University of North Carolina, as well as an alumnus of said Theology, Medicine, and Culture Initiative at Duke Divinity. And last year, I was working with Martha as like a research assistant, but helping get all this going. So,
Hello, I'm Namrita, and I am a second-year master's student at Duke Divinity School doing the TMC Fellowship, and I am also pretty new at volunteering with Samaritan, but I've gotten opportunities to work a little with their initiatives on this team.
Hi, y'all. I'm a second-year TMC Fellow, Theology, Medicine, Culture Fellow at Duke Divinity, as well as a second-year MDiv student. So I've got one more year before I'll be going to med school. I'm applying to med school this cycle. I began at Samaritan Health along with Jonathan as a community health team coordinator, and so have really been had the pleasure of working with Martha in trying to envision what this community health team would look like. And it's been really impactful, and hope you guys will learn a lot from our experience.
Great. So a little background about Samaritan Health Center. Samaritan is in the category of a free clinic, a faith-based free clinic. It started in 2009 in Durham. Initially, it was in the top floor of a women and children's homeless shelter. And that actually impacted how it was developed in some ways. It created some of the walls because it was initially really just for clients who were at this health center. So that was in 2009, and it expanded since then. The vision of Samaritan is to envision a community where all people have what they need to flourish, with a mission of sharing the love of Christ by serving those in need. I'm sure that many of you at the institutions you work for have worked hard to develop core values as well, but these are ours. To believe that no one is beyond hope of redemption, to understand that we all have something to learn, are dependent on God, and everything is not our own, to take concrete action to help others in need, to be Christ-centered, and to offer the best possible care through our staff, volunteers, and partnerships. Our patients at Samaritan are area residents with some proof of identity. So you don't have to live in Durham. You don't have to be documented. You have to have a household income, as with all free clinics, of less than 300% of the federal poverty level, which is about $47,000. I'm almost in that. You have to be uninsured or underinsured. So we don't accept Medicaid or any insurances. And this is a little bit of an issue because people flow on and off insurance. And it's, I think, part of why free clinics are challenged to maintain, some degree of stability. In the last year, we had approximately 3,000 patient encounters, about 800 patients total, and about 300 new patients registered. So that gives you a sense of the size of the clinic. Our demographics, about 60% Latino, 20% Black, 18% white, a mix of others. Nami will talk a little bit more specifically about our refugee population. It is really, Samaritan was founded by a medicine peds physician, and it's been very adult chronic illness focused. There's been, with more children in North Carolina not on Medicaid, we have had increasing percentages of pediatric visits, but we still don't have robust pediatric care. We also offer vision screening and nutrition. And then Durham as a city is tiny. When I see folks here talking about Chicago and LA, I'm like, we are this big. We have about 300,000 in the greater sort of Durham community, growing at 1% to 2% per year. About 40% non-Hispanic white, 30% African American, 16% Hispanic. It's in some ways a very wealthy area in that healthcare and industry are common, and the unemployment rates in Durham are relatively low, 3% to 4%, but it's increasingly expensive to live in Durham. Housing prices increase almost 10% annually. Erin in particular is working with Unhoused and sees that as well as the transitory in and out of housing, and some of the places where you all are as well might do these pit counts, the one night in the year count of those who are sleeping in the rough. And so by the pit count done in Durham in February of this year, there's about 1,500 people sleeping on the house. But that does not count folks who, were on someone's couch last week. This night they're in a shelter, next night they're sleeping in their car. So we know that the unhoused rates in Durham are quite a bit higher. And about 11% of adults living in poverty, 15% of children living in poverty. So very high rates of children living in poverty, and a lot of families living on the streets. In the Durham County Community Needs Assessment last year, lack of healthcare access was named as the number 2 health issue. There is one primary care clinician per 800 patients, which is actually better than North Carolina wide, but this is just so unevenly distributed in terms of where you could actually get access, even if you had Medicaid. Medicaid expansion came late to North Carolina. We're hoping it sticks right now. And with that, about 4% more of the Durham adult population qualified for Medicaid. But as I said, that's very uncertain right now. And there's 2 large medical systems, a large network of community health centers, private and group practices, but still so many limitations on accessing care. And so we're in this in-between place. We're a free clinic that started in a homeless shelter that honestly is still not as well known as you would hope it to be, even though we actually could serve many of these folks. So with that background, I am going to pass it on to Erin without tripping on the cords.
So we thought, as the students on the panel, that we would give you all our perspectives as to where we're coming from. So Martha has, or Dr. Carl has mentioned where our specific lenses are and where they're focused. And so Jonathan has worked extensively with Latino populations. It's near and dear to his heart, and he'll explain that. And Nami herself has also worked with refugee and immigrant populations and can speak a little bit more to the experience of getting healthcare and the sorts of issues that face that community. And then for me particularly, I'll talk about the needs of our unhoused neighbors, homeless neighbors, folks who are in transient housing. And so, yeah, I started at Samaritan Health Center after joining TMC, Theology, Medicine, Culture. Again, we keep throwing that acronym around, but started there. And my entrance into free and charitable health was through a nonprofit called Open Table Ministry. I was placed there by Martha, who was our spiritual leader throughout our spiritual formation instructor. And I actually was a little bit irritated that I was placed at Open Table. It was one of our first times partnering with them, and there was a lot of incredible clinics that were out there. I knew that Martha was deeply involved with Samaritan Health, and I really wanted that interaction. And so coming into Durham, I showed up at 6:45 a.m. to this place called Open Table Ministry, which what they do is they primarily serve as a way to get folks housing ready. And so what that looks like is anyone who is experiencing homelessness or instability in housing can come to this nonprofit. They ring a doorbell on a church door, and they're invited up to the top floor of a church. We're not affiliated with the church, but that's where Open Table is housed. And we listen to their stories. We get to know them, and we just determine what is their next step, the next right step for them getting housing ready. And what that looks like is having documents. If you're living outside, a lot of folks get their wallet stolen, so they may not have an ID. They may not have birth certificates for employment. They may not have social security cards for employment. They may not even have access to their medical records or know how to do that. So we're really partnering with them to help them navigate the continuum of care, as we call it, within homeless services. A huge part of Open Table's ministry is on Tuesday mornings, every single Tuesday morning, rain, snow, sleet, shine. We do something called Free Store. And the motto of Open Table is overcoming homelessness through the power of community. And Tuesday really encapsulates that. So it's in the parking lot of a church right across the street from City Hall, which is really ironic. And so we have folks gather there from all over the Triangle. And at Open Table Free Store, they're able to get free clothing, free shoes, backpacks, wallets, hygiene items once a calendar month. Also in that parking lot are partners throughout the city who come and set up tables. Sometimes we've had Samaritan Health come out there just trying to get folks knowing what their options are for healthcare. Right now, we've got a mobile bus who comes out with a Duke physician. We've also got folks who come and actually do eye care and free showers, free haircuts. So even if you're not able to get clothes from Open Table, we've got a community developing. And so I share all that to say, through learning their stories, through being in the community, I've firsthand gotten to experience through friendship, what is it like to be sleeping outside. And the last thing that's really on your mind is when was the last time I went to get my physical checkup, or what's going on with my teeth. Oftentimes hearing how folks, their first entry into healthcare is when something doesn't work anymore, when something's really paining them. And that for me has been really eye-opening and has informed a lot of my work within Samaritan Health.
I guess to give a brief on sort of my perspectives and interests, this is actually a really fun photo with myself and Dr. Carlo and another physician who's Dr. Lee, who's Amy Lee, who's worked with us. We were at a school event for sort of at-risk youth and giving a presentation on what it's like to become a physician. To mostly Latino and Black students in Durham. And I'm Latino. My family's from Venezuela. I'm a first-generation American. I speak Spanish. It was my first language. And I got connected with Samaritan to get clinical experience hours for medical school. But I did that by interpreting, and over my like a year and a half before applying to medical school, while in TMC with Dr. Carlo, I logged like 200 or 300 hours of interpreting work, and started doing this kind of work, reaching out, education, being with folks, and inspiring people. So I have a real heart for education. I have a real heart for Latino communities. That's sort of where I'm coming from.
Okay, so similarly, I'm an immigrant, so that's really shaped my interest in like refugee populations and immigrant populations. And coming to Durham, our spiritual leader assigned me to World Relief, so I've gotten the opportunity to spend a lot of time with refugee communities and just like be in fellowship with them, and also work on like education aspects with both children, high school students, and now I've also been working on like ESL stuff with refugee women. And simultaneously with Samaritan a little bit, I've gotten the opportunity to help with refugee exemptions for like citizenship stuff because of like language issues. And so I think that's just like given me some more like insight into what it means to like be part of their community, to be able to bridge those gaps, to really see what they need, and to draw a greater awareness to how we can like help them in those capacities.
I don't think I have to say anything else. Are these not amazing students? Do you not want them? So very grateful. Very grateful. I think what I have to say, I'll just keep coming out. So when I took on a role at Samaritan 3 years ago, so I left like full-time academic practice, and this is a different stage of my career. And I have always been the kind of physician who enjoys patient care, but was more committed to community and not the one-to-one, but like what's happening out there that brought these folks to me. I wanted to establish a community health team. So frankly, I thought up this idea. And I also just think that there's like unusual barriers often between clinics and communities that don't necessarily have to be that way. So we are modeled, as about 50% of Christian health centers are in the country, on the idea of the Good Samaritan, and named after it. And the point I would want to make here is the Good Samaritan went out into the community, right? The Good Samaritan didn't wait for the one who was fallen, wounded, and robbed on the road to crawl to them. They actually went out to the road and found them. And so that sort of image is important to me. And we talk about community health as being a little bit of a different framework or lens than these other two issues. So public health, and I have a public health background, I believe in public health, our country needs public health, particularly right now, so public health is like the science and research behind protecting the whole population, the population writ large. And then population health, which has become a term more common just even in the last few years, is a sense usually coming out of healthcare systems of how do we be sure those who are our patients are as healthy as they can be when they're not with us, and looking at health status and management. But community health is a much broader idea and touches on many more social determinants. The sense of collective well-being of a community, paying attention to those most vulnerable. So public health has the responsibility to care for everyone. Community health has the privilege that you can actually focus it a bit. And it may look at prevention and disability, but also this sense of narrowing the gaps to be with communities and not just for them. And so for Samaritan Health, what we perceived of is how can we contribute to the flourishing of vulnerable communities from which our patients come, whether or not the individuals are or will ever be our patients. So at Open Table, Erin's involved with lots of folks who are unhoused. They actually might get their health care elsewhere. They might not get health care, but we consider our work with them to be contributing to their flourishing. It also just lowers the barrier to go out there as a doctor and be chit-chatting and offering them socks and, being in that space to lower those barriers. And so that happens in each of these situations in the way our community health team is involved. So we focus on housing instability, those who have been justice involved in a house that particularly houses folks in Durham, refugees and immigrants and the working poor, and those who can't access health insurance. If you are interested in like the logistics, I went through about a year of like prep work for this, including we did a situation analysis. I visited I interviewed about 24 clinics. I visited about 8 of them, asking what do you do for community health? It was fascinating to learn what other CCHF clinics call and do for community health. I met with about 40 different leaders in Durham that are within nonprofits in different sectors, and said, like, what would be most helpful to you? How could we partner with you? And from that, we have developed some of the activities we've been involved in. We oriented our board and staff. I would say, and this is being recorded, that was some of the most hard parts, because to explain what you're doing, if it doesn't involve direct healthcare to patients in an exam room, can be confusing. That might not be what folks understand, but we are continuing to work on that, and I'm grateful for the opportunity to do so. And then I established a way for students to get involved in this, and others as well. There's more than just students that are on the community health team. We set up a way to apply to be on the community health team. I'm not going to read this through, but HIPAA compliance, being involved in a seminar sort of orientation, actually doing a tour of the health center, and then committing to at least an event every 3 to 6 months for about a year. And we'll talk more about the timing of that. And some of the things that we've done have included sports physicals for mostly Latino boys that are part of a futsal league that is an outreach in Durham. Also, the Catholic Church, we have done adult health screenings at the Catholic Church, done hemoglobin A1Cs, lipids, depression screenings. We've done health education with the refugee resettlement agencies, there's a women's Afghan group at Church World Relief that I speak to on occasion, just to sort of say, like, here we are, we just want to hear what your concerns are. And so we've done some training around that. So we've had some activities around that as well. We've tried to build a sense of a team, and that is something that is an ongoing thing that we can probably talk about. So that's enough of my voice. I'm going to pass it over to Jonathan.
Yeah, so Dr. Carlo kind of gave an overview of our activities and sort of the requirements of the team. And now the three of us are going to kind of talk about the impact and our experiences that we've kind of had in our sort of respective areas of focus and passion where God's been leading us, and how we've kind of worked out this call to community health. So I'm going to talk about 2 things. And the first thing I'm going to talk about is medical student volunteers, subtitle Planting Seeds. Medical students are a very interesting group. On the one hand, they're very passionate, driven individuals. On the other hand, sometimes it can be difficult to pin them down because they're so passionate and driven. I kind of have their transient trainees versus motivated innovators. Students have busy schedules. They have lots of competing interests. Often the students who are available to volunteer are first and second years, and they're only around 12 to 18 months. As you can imagine, that's sort of, it feels like as soon as the students are starting to get their feet wet, oh, okay, next group. And they're often inexperienced, although they've been in clinical environments to be able to get into medical school. We all know, we don't know what we're doing until later. On the other hand, like I said, they're really motivated. They bring lots of ideas. They're dedicated to serving others. And they often learn well on the fly. They're quick learners, quick studies. And so one of my biggest efforts as part of our community health team was sort of, I used to call it like grassroots recruitment for our efforts. And I was also involved with the Latino Medical Student Association and the Christians in Medicine group at the UNC School of Medicine. And a big part of my job was like hounding my classmates almost every day, whether it was in group meetings or in person or sending out emails or nudging other leaders in our organizations to do so. It was really rewarding. And these are some of the key takeaways for successful recruitment, or at least what I feel like I've had to do to get people involved. And number 1 is relationship. The best way to get someone to care about something you care about is for them to get to care about you first. And often I'm looking at these folks. I've tried not to pick a photo that you can see their faces, but they're all wonderful people who I've gotten the chance to build really good friendships and relationships. People I know whose hearts are for Jesus, are for serving the poor, are for serving the community. And building relationship is the kind of the doorway. Repetition with medical students, whenever they have a fire hose of information coming at them every day from their preclinical coursework, you need to repeat at least 3, 4, 5 times that an event is happening at this Sunday at Immaculate Conception after the Mass, where we're going to screen like 50 to 60 people on like hypertension and diabetes and high cholesterol. And repetition is key. Collaboration, ownership is sort of the third thing. If you can get someone to care about it, and then you tell them about it enough, they're going to be even more excited to get involved if you give them a sense of agency and ownership over the thing that you're trying to kind of inspire them to do. And so empowering students, even if they weren't, whether they actually officially joined our community health team or not, empower them to kind of have their own small little leadership roles. Delegating is an awesome thing. And that also helps with continuity down the road. And then the fourth one is sort of inspiration, and this is the one that I like the most. I have also a pastoral heart within me. I got my MDiv, and I'm still discerning a call to ministry alongside medicine. Maybe discipleship is another way of saying this, but like the way to create a culture of caring for the least of these is to like just remind folks and like, this is why you're here. Medical school and its hidden curriculum are going to point you in a very particular direction of usually subspecializing, focusing on yourself primarily to be able to achieve your career goals. And to an extent that makes sense, right? It's a rigorous education, training, and we need to be focused to become good physicians and take care of people. But oftentimes that practice can sort of decay our hearts. We lose our first loves, as the Apostle John says in Revelation to, yes, anyway. And I'd like to tell our students, like participating in events like this with Samaritan or with other volunteer places, what it does is it rekindles us. It may not be something we can do consistently now, but kind of like we say, even just reading scripture a little bit every day is enough to keep us going. Like doing a little bit during your preclinical time is going to remind you why you're here. And that's sort of, it's really important if we want to make not just medical students, but physicians who care about the poor. Yeah. How am I doing on time? Okay. The second thing, I'll be a little bit faster. I sort of already talked about this, but that I've focused on is Spanish-speaking populations. I poured a bunch of effort into our screenings at Immaculate Conception, the Spanish-speaking service at a Catholic church in Durham. And I gave kind of these 3 headings as like things that are important for working with Spanish speakers. Idioma, language. You got to have the actual language to be able to communicate. Without that, can't do much. And it's often better for the language to be coming from the person of care than through an interpreter. You can have more closeness. With that comes understanding, or entenderse. And by that, I don't just mean like understand the words, but like actually understanding a person, where they come from, to have a sense of the cultural expectations and norms. This picture depicts me with a baby that I stole from one of the people who was coming through our screening, borrowed, sorry. And one of my professors at the School of Medicine who teaches us medical Spanish. And one of the first things he taught us was whenever you have a Spanish-speaking family and a kid is there, you have to touch the child, or else it's almost considered rude, like you're not acknowledging their existence. And so me borrowing this baby that can be off-putting oftentimes for Americans, but it's like, it means you're trying to get involved in the community for Latinos. And the last one, encuentro, or encounter. Those moments, like Latinos are all about encuentros, coming together, having an encounter with one another. We need folks who are willing to know the community not as saviors trying to come in and do something of their own, but as friends, walking hand in hand, mano a mano, encuentros entre hermanos, encounters among siblings, brothers, sisters. And it's been a great time. I'll pass it on.
So I guess with serving the refugees in Durham, just historically around 4,000 to 5,000 usually come to North Carolina, around 1,500 to 1,800 to Durham County. And unfortunately, with everything going on in January 2025, that pretty much was halted or limited, and except with some Afghani, Iraqi, Ukrainian, and Cubans who kept coming through the summer of 2025. And then also Samaritan Health Center does not see patients on Medicaid. However, and initially refugees were given 12 months of Medicaid, but now that's been reduced to 4 months, which has increased the need that they can get from us. But the question is more how we can provide in that increased space, and how we can increase support of refugees without access to care. So some of the challenges with caring for refugees can be communicating the concepts of like insurance and emergency or non-urgent care, which can be difficult for them to understand coming from a culture that may not have that. And also considering lack of transportation, since most of them will utilize public transportation such as buses or walking. So how we're able to bridge that gap and like get them to these initiatives like free clinics and stuff. There can also be a tremendous amount of fear or lack of trust after the experiences they've gone through of trauma and isolation, and clinicians being from a completely different culture and background can face obstacles in understanding the layers of cultural and religious issues, which, as Jonathan was saying, I think that requires a level of like fellowship to be able to bond and understand them coming from where they are and rebuild that trust. So some of the needs are to create an awareness in these communities where they're living and socializing, being a part of, being in fellowship with them, and having high quality, appropriate language interpretive services, which I always, also as Jonathan was saying, I think it's always important to have providers who can speak in the languages, as that's an important level of communication that's often missing. But interpretive services, if they're appropriate, will help. And also deepen the partnerships with others serving refugees, and an increase of funding for these specific initiatives. So how we get these informations to refugee families in ways that they can easily access and understand is like a big challenge, and something we need to continually think about as we're serving these communities and rebuilding our trust with them after these experiences of trauma.
Thanks. And now I'll talk a little bit about some considerations. I don't know where all of you are coming from, and hopefully during this workshop you've been thinking about the specific needs of the population that you're serving. But if you find yourself like Durham with a rapidly growing unhoused population, it's certainly useful to be thinking about what are the certain considerations you should be thinking about as you're engaging with people who are sleeping outside. And so I've kind of broken those down into familiar, flexible, and focused. So the number one question I get asked if I was to tell someone, hey, come to Samaritan's walk-in hours, or hey, come to Open Table and do this, is will you be there? And so the piece that oftentimes people experience when they're sleeping outside is this dehumanizing look away or forgetting your name. And when you, as clinicians or volunteers, take the time to learn someone's name, have a conversation with them, and just chat. What are you doing out here? If you're driving and you're at a stoplight, and you've got little flyers, I'll put plug for that. If you are at a clinic, or if you feel like you don't ever really know what to do, that awkward moment where there's someone who's outside with a sign and you're like, do I look? Do I not look? Having a little flyer of resources is a really incredible way to bridge that gap between you and your car and someone who's outside. Oftentimes I'll roll down my window, be like, hey, I don't have any cash with me, but here's this flyer to Samaritan Health. We have walk-in hours. Like, if you ever need anything, let me know. And that question often is, will you be there? Because I'm not going to come and show up, and then next thing I know, I'm, being kicked out, or someone's really rude to me. So really taking that step to be familiar with someone and break the barrier. And I think a big part of that, if you ever find yourself in the community, and what I've really valued about the model that we've been trying to roll out in Durham, is being just in the community in a way that I'm not here to give you a service. I'm not here to tell you what to do, but I'm here to learn who you are. And your visibility at events like kids, preschool's family event, where you're there with a bunch of books and you're just tabling, ways to get involved with already established routines within the community is incredible. So Open Table, every single Tuesday they've got that free store happening. So folks know if they want to reach out to the homeless population in Durham, they ought to be at Free Store. And so thinking about what happens on a weekly rhythm within your own community keeps that familiar, and then starts to imagine your face and your clinic in that area. The next point about flexibility. And so one of the biggest barriers that face folks who are sleeping outside is, please don't try to say, yeah, come on Monday at 4 p.m. and that's when we'll have this appointment. Appointments for folks who may not have access to a phone tomorrow, where their phone could be taken, they might not have access to getting it charged. They don't even know what day it might be. That's a really common occurrence for folks. Being extremely flexible as you can be. That's why walk-in hours on a public bus route is one of the most accessible ways to reach folks who are sleeping outside, especially knowing your community in a way that you can give direction. So if I was to say, here we're standing on Main Street, make a left at, but if you know the landmarks that folks might be around, and being able to guide them through the town in a flexible way, thinking about how to reach someone who may not be privy to take bus 1 and then go here. So thinking about how you know your community best, and reaching folks in that way. And the next part that's really critical to the geographic situation Durham finds itself in is we're called the Research Triangle. So we've got Chapel Hill, Raleigh, and Durham. So it's often that folks are transient, and we may see someone who's coming to Durham to receive Durham care, but they're sleeping in Chapel Hill, or they're getting some other service in Raleigh. And so recognizing that when it comes to follow-up services, you may need to get in the car and drive around. And so I think of one gentleman who's really near and dear to my heart, and he's a wheelchair user, and he made it to the top of the list for housing, and we didn't know where he was. And this offer was expiring in the next day. And so we all got out and we drove around the triangle to go find this guy. And so being flexible on your part of recognizing that sometimes you got to go out there and get to folks. And then finally, focused. I'd love to tell a story on this point. There was a family, family who's frequently coming to Free Store, got to know him. He's got 2 small kids, single dad, and they're sleeping outside. And there's a lot that needs to happen in order for him and his children to receive healthcare and have a flourishing life. But what was most pressing for this family was the youngest son needed a form filled out that would allow him to go to school. And so you need certain health screenings and checks to say, okay, he's eligible to be in school. He needed this form filled out. That was about his dental care. And what we could have done there as a clinic or as open table have been like, okay, how can we just pivot to stay in the bubble that we're used to? But rather being focused on the next right thing for this family was to make sure that this kid is in school, eating meals, is not outside, not missing instruction. English was his second language. And so that was the most important move for us to get that family into a state of flourishing. So being really focused on what is directly in front of you, what is the practical need that you can meet? One of the most incredible ways of entry points to someone and their health and their lives is giving them a pair of socks, giving them a bowl of soup, giving them a snack. I know Dr. Carlo carries food line gift cards. That is a way to, if you don't want to give out cash, or you might not, I carry a box of like Belvita granola bars and water, especially as it's summer, buying a bottle of a case of water and just keeping it in your car. Being able to hand those things out. So the most practical need in front of you is somebody's hungry, somebody's sleeping outside. It may have rained last night and they need an umbrella or they need a change of underwear. So once you are able to meet that need, you know the need is incredible and there's so much more than one individual often can do. But being able to fill that need that's directly in front of you is really incredible. So with that, we'd like to move on into the practicalities and challenges that we've had. Does anyone have any questions first about what we may have discussed? Okay. So some practicalities and challenges. So Jonathan and I got to be the community health team coordinators. And in this role, we've kind of identified the certain things that were really challenging for us to continue the work that we wanted to do. And a big part of that was maintaining energy. So starting this community health clinic or community health team, it took a lot of time commitments and shifting around of our own schedules where, like we said earlier, finding those weekly rhythms that Durham already has. A lot of things happen on Saturdays, on Sundays after church. They're happening Thursday nights for parent-teacher conferences. Finding ways to maintain that energy amongst your volunteers as well as amongst your staff was pretty challenging, especially moving around your own schedule. And that's why I, again, would say find those listservs, those emails that you can plug into and you start trying to navigate that. How can you maybe shift your clinic hours or how can you shift certain things in your own schedule to be present at those events? Jonathan mentioned this, and so did Nami, about relationships within the community are the foundation. And I think you've probably heard that so many times of build relationships, be somebody's friend. So real. A large part of what Martha did in her situational analysis in the beginning before we started this team was having those interviews and understanding who is out there and what are they doing. And once you show up, oftentimes what we did was exactly what's in this picture is we had a table and a tent on a rainy day when people can come and get under our tent. And we're just asking folks, why are you here? What are you doing? This is what we do. Oh, I'm insured. I'm not eligible, but can I take a flyer and give this out? So those are the ways that you kind of get your name out there. You may not be doing what you really want to do. And Jonathan spoke to medical students can be really difficult to get engaged because standing at a table may be hard. But that is the most important part, is being in your community. And then retention, obviously, for those challenges we mentioned above, can be difficult. And finding creative funding sources is fun. We ended up going to a basketball tournament and entering into, well, we didn't end up entering because somebody rolled their ankle, but we showed up at this basketball tournament and we were dancing, we were having fun, we're out there, we're supposed to be given first aid in case one of the players got hurt. And this is a community run event. And just being out there and dancing and having fun, the winning team decided to donate the money to us. So they got to choose the charity that they wanted to donate to. And we got $1,000 for showing up to this community event and dancing and having a good time. So finding ways that you can fund what you're doing for those little extras. So like those squeezy balls that we have, we've got some lip balm, some hand sanitizers to give out. And then finally, one of the biggest barriers was having enough experience amongst our volunteers. So there's a lot of really eager undergrads that email us like every other week. And they want to volunteer and we want them to volunteer. We also know that we have a big need for the language, folks who can speak the language of our refugee immigrant populations, as well as folks who feel comfortable running hemoglobin A1Cs and could do mental health screenings. And then finally, in our last few minutes before, we'll do some reflections on what we've learned, Jonathan and I, on how it's impacted us as students.
Yeah, I feel like I've kind of already said a lot of it. These are just two silly pictures of us because we've spent a lot of time working together this last year. I would say that like the experience has been one of the most meaningful and impactful that I've gotten to do. And I don't regret it for a second, even though it perfectly coincided with my preclinical time from like January to December, right before I took step one. It was worth it. It is sometimes hard to not see the same level of passion that you have in the folks you're trying to inspire to help you. Yes. And sometimes you just have to keep going. You have to keep inspiring, keep encouraging, keep reaching out. And then maybe someone will be willing to kind of take up after you. Yeah, and keep doing the good work, the good fight, the good race, whatever biblical image or analogy you want to use. What about you, Aaron?
Yeah, I would say, and we had a good conversation about, I think one of the toughest things, in your point about not seeing the passion in other students who want to serve the poor, is it can be heartbreaking, but also trying to be creative about how you reach your peers and reach the folks in your community. And one thing that med students are pretty interested in, and anyone who's maybe early on in their career, is what skills they're learning from things and how this might impact them or help them later on. And while there's some folks who just simply want to serve because that's what they feel called to do, there is a level of trying to speak to that as well. And so I would say a big reflection of mine is when talking with volunteers, being really specific about what are they doing and what are they learning here, and thinking about that for my own self. So how has my character changed while being in this community? And a large part of what I see as a skill or something I've gotten from this is, for the first time as a student, as someone who's from Virginia, I lived in Boston for a couple of years and then I moved to Durham, and being in a community health team like this made me really feel like I was a part of the community and that I was in it. And that growth and that development cannot really be understated when you do run into someone and you can say, oh, I know where that CVS is on the side of da-da-da-da-da, and this is what you need to do, and this is where you need to go. And being able to bridge those gaps is so incredibly important, even if you're just in the town for the 4 years or the 3 years or the 2 years that you're there for a fellowship or a degree. And so that knowledge, that personal, tangible, on the ground knowledge is essential, I think, to giving real good whole person care. And then on top of that as well, living amongst the folks that you're serving, being out there and going to their events. I cannot reiterate that enough. And then also just having fun. This is me at Free Store and so many animals. I won't tell that story, but I ended up being voluntold to foster a puppy, and it was like the worst month of my life. But there's animals out there, and there is a lot of ways that you can meet the needs of others and care for them in whole person ways. And so finding those moments of joy when you're out there is really, really important. Awesome. And so we'll leave you all with this part. Martha, would you like to do this part? Or
No, I think we just have a minute or two. So.
5 minutes? Great. Okay. Okay. Awesome. Yes. Yeah, absolutely.
We are looking up a brain medical clinic here in the Northern Section next month, so I have a questions for you. You guys have done a really great job. One thing that we're planning to do is how do we get the information directly to families in ways that they can easily understand and access. So I know that's one of the questions up there, but it's really understanding the answer
Yeah, I think one thing to do would be to find out who is serving refugees in your community, whether it's a formal resettlement agency. There's 14 of these volunteer resettlement agencies get paid by the government. And even though there's not incoming refugees right now, they may exist. Or they may be nonprofits, to figure out who's already, or maybe there's churches, who's already in touch with those folks and really go to them. And I think that's what's made a difference in terms of Samaritan, that that's work that I've done for years in other contexts. So Church World Service would call me and say, would you come over and talk about bleeding, uterine bleeding with these Afghani women, and just sit with them. And so like going out there, and I could give you some ideas about that. I really think particularly with refugee and immigrant populations, you really need to go to them first. And that's why going to the Catholic Church is important. There's a food bank that we've hung around at, part of our team, so that you're seen as trustworthy. And I just want to reiterate that the community health team at Samaritan is not about increasing Samaritan Health's patient visits. It's more this sense that we led with, that we want to contribute to the flourishing of the communities from which our patients come. And to keep like harping on that sense and getting out there is, I think, what matters most. But I'm happy, I can give you my email. I'm happy to share any of this. This is one model that we created. Some of it worked great, some of it not so great. It is continuing to evolve and maintaining the energy. And then having someone who's steady behind the scenes to continue it as students move to different stages of their education. I'm a paid provider, very part-time, less than a day a week. Yes. Yeah. Yeah.
What's the practical means of meals and seeing like what's in front of you? You mentioned socks.
Practical needs. Yeah. Bus tokens, food.
Oh, yes. Toilet paper. Having toilet paper, having rain ponchos, really cheap rain ponchos that you could hand out. Snacks and water, huge. Socks, underwear, jeans, those are a little more expensive, but getting folks to just give shoes away for folks who are always walking around. Smaller things that you could keep on hand would be like alcohol wipes for folks who use them for a variety of different reasons, hand sanitizer, ways to just kind of keep their own hygiene. Because, yeah, I think if you can partner with a place that has access to showers, that is so incredible. That's one of the biggest ways you can definitely serve folks. And I wanted to add, does anyone have a question before I talk about? I know we're wrapping up on time, but I want to say too, with volunteers, as you're beginning to start something like that, being some way to keep volunteers on a schedule. We mentioned that one of the requirements was that you go to at least one event every 6 months, and having a way to regularly be in your volunteers' inboxes and show them what you're going to be doing, like some sort of community letter or even just an email thread. This is what we're looking at this month, next month. That's a really important way to keep retention up, because if you kind of come up one time and you forget Samaritan Health exists or forget your community health exists, you're losing your volunteers.
Repetition.
I will say at CCHF, a plug for Jesse Thomas's student workbook on upholding the vision would be a great study to think about community health. It's a really nice biblical study. And I mean, I think we had a vision for developing a sense of community within our community health team. We tried to do one potluck. I would love to see that continue to develop. People are busy. It, hasn't taken off thus far. Any other closing comments or questions? I don't want to hold you guys hostage in this room. Okay, well, thank you so much. I'll hang around a few minutes. We all will, if you have questions or want to follow up. Thanks for being here.
Thank you all for showing up. Last and final thing is, if you would please fill out this survey. They've done a nice job and put it on their slideshow, which is awesome. This just helps us get an idea of what people love for conferences, for speakers, and helps us improve for years to come, and also helps them understand what was beneficial and not. So we appreciate it, and have a good day.
Thank you.
Yeah.
Yeah.
Great.